Birth control shuts your hormones down. Hormone therapy replaces them. And yet we keep using one like it's the other. Today we're clearing that up because your ovaries deserve better than confusion. Hey y'all, welcome back to Hump Day Hormones. I hope you had a great Easter. We are back at it. We have something so fun today. I wanted to have my son, George, on to help introduce this podcast, and I think you'll understand why. His sister has been on it, and that just wasn't fair. You know, a good sibling rivalry, he has to be on too. So he's going to introduce this episode for us.
What's up, podcasters? It's your boy George. I'm here on episode 7. I'm with my mom Jill and her friend Courtney. Today, they will be talking about differences in birth control pills and hormone replacements. Bet! Take it away, Mom.
George, that was awesome. That was the best one yet. I loved it. We were talking on the way up here, and we really had to go over this hormone replacement situation. He said he wasn't real sure what birth control or hormone replacement were. And so, you know, I think there's a lot of general confusion with a lot of people about that. They use them interchangeably like they're the same thing, and they are not. So we're going to clear that up today. Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. Hello, we're back. We recorded that little intro yesterday with George because I didn't want him to have to miss school, and we record on Mondays. But now Courtney's back with me, and she just watched it for the first time.
Sweet George. You're so cool, George.
George is so cool.
He is.
Yeah.
He is like a pro podcaster.
I know.
Love it.
I love it. He thinks we're famous, so we'll just go with that.
We'll take it.
We'll take it. Go with that. But y'all had a good Easter?
We did have a good Easter.
Yeah.
Yeah. We did like an Easter egg hunt Saturday night with like my group of girlfriends and all of our kids. So I think between all of us, we have like 19 or 20 kids. And so that's plenty to do an Easter egg hunt with. And we had a pizza party and all that, and then went to church yesterday morning, and we had a good day.
Yeah. I think I saw those pictures on social media with it's like a lot of girls.
Yes. Yeah. It's pretty like half and half. I feel like we've got a good mix of both.
Yeah.
So it's a lot of kids.
Yeah.
The age range is 1 to 14.
Oh my.
So we had,
And it's nice when you get a group of kids that big if you can be outside, because it's just like,
oh yes, yeah, they were outside
where you can't destroy anything.
Yes.
Yeah. Oh my goodness. Okay, well, we're going to get into it. I feel like this is one of the most common mistakes that I see in clinic is that people come in and they're, say, maybe 48 years old or 51 years old, and they're like, you know, they're just on their birth control pill, and somewhere along the way somebody told them like, well, you don't need hormone replacement, you're already on this birth control pill, so just stay on the birth control pill. And I'm like, those are not the same thing. And really, Not even close. So and there's so many things that you're actually down regulating by being on a birth control pill that you would naturally be making, like progesterone, testosterone. So, it's more than just like the estrogen component. I think it's true you would like blunt your hot flashes. And so like you can kind of make yourself feel like you're not going through menopause because you're not having a hot flash. And we talk about that all the time, that we have incorrectly labeled menopause as hot flashes. But it is so much more than that. And so I just want to like break this down. And I think once somebody breaks it down to you, it's like super easy to understand, but nobody ever broke it down like this to us, even in med school or residency. And so I get why there's full-blown OBGYNs and for sure family practice doctors out there thinking that they're the same thing. So I don't want y'all to think it's the same thing. So here we go.
Yeah. So, I mean, the way that a birth control pill works is it literally just like shuts down your own ovaries, and like overrides your own natural hormone production to suppress ovulation and prevent pregnancy. Obviously, like that's what we're using it for. But whenever we're looking at like hormone replacement therapy, that is designed to replace what your body is losing, kind of help support physiologic function, and just treat symptoms of hormone deficiency. So we just want to replace back like what you are lacking, and not completely shut down your system.
Yeah, I think that's the thing. And when you shut down an entire ovary, you're not really like taking over either. It's not that birth control has enough estrogen to kind of give you like what you're normally doing during a cycle would be spiking that estrogen way up there. Not that you need to do that. And that's not what we're doing with hormone replacement therapy either, but you're never getting an estrogen peak. Your estrogen's relatively going to be pretty low when you're on a birth control pill. And then you are shutting down the ovary completely. So everything else out of the ovary, the progesterone, I mean, that's the whole point of birth control, is that you don't ovulate and that you won't get pregnant. And so if you don't ovulate, you don't make progesterone. And then if you shut down the ovary completely, well, then you didn't make testosterone, from that source either. And we'll kind of go through how much of that, how much actually gets turned off of testosterone, because you do still have your adrenal production. But when we're talking about this birth control, we're talking about birth control pills. So combined oral contraception. So estrogen and a progestin, and that's usually in a pill, a patch, or a NuvaRing. And so if you've got something like a Nexplanon or an IUD, those are not shutting down your ovaries. And so, there's different nuances in there, but I mean, for sure, birth control pill, and then birth control patches and NuvaRing too. Those combined types. So the estrogens are different. Like what we are giving people with hormone therapy is 17 beta estradiol. And so that's like total chemical name of it. It is bioidentical. It is chemically identical to what comes out of your ovaries when you ovulate. It is literally the same molecule. It binds the same receptors. It's metabolized the exact same way. It has the same biological effect. So that is much gentler on the body than what is in birth control pills. So birth control pills use ethinyl estradiol, which I guess is the whole problem with organic chemistry. Like, well, that sounds kind of like estradiol, right? It must be the same thing. But ethinyl estradiol, for the organic chemistry nerds, has an added 17 alpha ethinyl group. And that changes a lot of things. That, makes it synthetic. It makes it much more potent and much more like bioavailable and harder to break down through the liver. And so that is a big deal. It's not just that ethinyl estradiol is like a synthetic, stronger version of estradiol, it's that it has a completely different behavior in your body. So ethinyl estradiol is, more liver active. Mm-hmm. So it's going to have even more effect on raising our clotting factors and raising your clotting risk, which we'll talk about here in a minute. Mm-hmm. And then that structural change, that added 17 alpha ethinyl group. It's so weird to me, but this is like the whole thing with like creating drugs, is like that you can change one tiny thing like that and have this big effect. But that tiny little change makes it resist the breakdown in your liver. And that's on purpose. Like, we need it to hang out longer. We need it to be stronger, because the whole point is for you not to get pregnant. So like, we want no room for error. Please hang around a long time, and please suppress my ovary so that I won't get pregnant. And so it's designed to like be so strong that it overpowers that natural system. And so that is awesome if we are 22 years old and our whole goal in life is to not get pregnant. And we probably have a ton of testosterone production anyway from our adrenals. And maybe we're trying to shut some of that down so that we don't have acne. And I don't know, I guess maybe progesterone's not a big deal when you're 22. I guess you're just like in a good mood all the time.
You probably just sleep good and everything anyways.
I don't know. Yeah. I mean, I feel like it's like just a different phase in your life when you're just like zoned in on like, I just don't want to get pregnant, and there's some prices that I have to pay for that, and that's okay.
I think it's really interesting, and I think we've talked about this before whenever we talked about like gut health and all of that kind of stuff, the like effect that birth control pills can have on your gut and how you absorb like nutrients and vitamins and things like that. So you'll see like, maybe deficiencies or low vitamin levels, and maybe thyroid conversion not as like optimal as it should be. And sometimes that can be tracked back to like, well, you're on a birth control pill and just kind of the way that it works.
Yeah, that's one of those things that happens through liver metabolism, is like raising our sex hormone binding globulin, which is going to bind up your testosterone. And then also raises your thyroid binding globulin. So you're going to have less free thyroid hormone. So there's some big things that happen when you take such a long time to get through the liver, and you're just so bioavailable like that as ethinyl estradiol. But, and then this led me down the rabbit hole of like, so what is in, like, if I'm prescribing bioidentical estradiol, that 17 beta estradiol that we're saying is bioidentical, what is in it? Like, you can't just have 17 beta estradiol probably and just it magically is in the form of a pill. So there has to be some fillers in there, like something to make the medicine like stick together and be a pill, and then not break down at the right rate in your stomach and with those, acids and stuff as you take it. And then if it's a patch, like it has to have adhesive and kind of carriers to get it across the skin. So there are other things like when we say bioidentical hormones, but if you could just like bottle up what exactly came out of your ovary, it's the best way that we have to do that. But there are, a little list of like 4 or 5 fillers in oral pills, and then patches is just straight up the adhesive. So, it's pretty close to being just straight bioidentical. So, and then transdermal estradiol, that's like even a whole different ball game, because they don't even go through the liver at all. So we're talking about that, natural bioidentical estradiol clears through the liver at a better, faster, more natural rate. Well, transdermal just doesn't do that at all. You do have that second pass, that we've talked about before, like with your gut health, like at some point it goes to the liver, but not that initial first pass where you get a lot of the breakdown. And so there's much less hepatic stimulation than oral estrogen. And in studies, transdermal estradiol has little or no measurable effect on like that clotting risk compared with oral. And so that came straight out of an ACOG committee opinion on postmenopausal estrogen therapy, route of administration, and risk of clot. So I think blood clot is kind of a big deal here. And that's what people usually kind of throw out there as like a risk, especially for oral estrogen. So it just seems like we should just talk about blood clots for a minute.
That.
Yeah.
I know. I love kind of seeing the numbers and breaking it down with like absolute risk versus relative risk. And if you don't know what that means, we'll kind of tell you what that means. So like just a like normal healthy woman has a baseline risk of about of getting a blood clot of about 1 to 2 per 10,000 women per year. And so, that obviously can increase with age, obesity, immobility, genetics, all of that. So getting on a birth control pill increases your clot risk from that 1 to 2 out of 10,000 to about 3 to 9 out of 10,000 women per year. So relatively, that risk is like 2 to 4 times higher, which dang, it sounds like kind of high, like you just doubled your risk. But but the relative risk there, or the absolute risk there, is it's only 3 to 9 out of 10,000.
Right.
But if you're looking at oral estradiol, like bioidentical hormones that we use, it just kind of takes your risk from that 1 to 2 baseline risk to 2 to 4 out of 10,000 women per year. So, I mean, it's just not, it's not much at all. I mean, it is there, but it's still low,
Yeah, and I think that right there is like a perfect example. The birth control with the ethinyl estradiol does it more. It's 3 to 9 per 10,000 than an oral estrogen pill, which is 2 to 4. And so it's like we make this huge deal about women getting on oral estrogen and it being this blood clotting risk, which when you have a patch and a cream sitting right there beside you, like, well, we could just use those and have like essentially no clotting risk.
Right.
I mean, because they're in the studies, they're like the 1 to 2 out of 10,000. They're back at baseline. And so it's like, most of the time, I feel like if you're like, well, then I just want the one with the least. Well, okay, that's easy,
Yeah.
But it's like, really, we're not talking about, and they say, oh, it increases your risk 2 times. Well, yeah, because it took it from 1 to 2 or from 2 to 4.
Right.
But it's not a massive increase. It's still 2 to 4 women out of 10,000. And so it's like, let's be real that that's still low across the board. Because even at the highest, like even on a birth control pill, which at the highest is like 9 per 10,000 women. Well, I mean, 10 out of 10,000 is the same as 1 in 1,000, which is, if you do it in percentages, 0.1% risk. So it's like, even in the worst case scenario, birth control pill, you're a 0.1% risk of a clot. And so, that's not that much. And so should we be freaking out about that and withholding like oral estradiol? Because oral estradiol is so cheap. I mean, it is dirt cheap. And so in people who can't afford other options or in other, areas of the country or maybe underserved kind of things, that may be their only access to estrogen. And so I don't think we should use a clot risk to withhold estrogen unless like they are morbidly obese or they have these other things that put them at higher risk. They're a factor V Leiden mutation person. Yeah. They are in a wheelchair and immobile. I mean, you have to kind of consider the whole patient, and then I know like Heather Hirsch talks about this all the time because she says, like, if we've been pregnant or we've been on birth control pills, or, I mean, if you've been pregnant, you've been postpartum, that you've sort of stress tested yourself against a blood clot. Like, I was on birth control pills from when I was 17 to when I was 30. And I've had 2 babies. And so that's a pretty good stress test on my body that I'm probably not going to clot with estrogen. So, I'll probably be okay with an oral estrogen pill. And so that's kind of a way to think about it. But because if we look at pregnancy and blood clot or postpartum with blood clot, their risk is up to 20 per 10,000 women, or postpartum 40 to 65 per 10,000. So I feel like we don't ever really talk about that your highest risk ever in your life as a woman is postpartum. So, I mean, pregnancy is way riskier. So that's always the whole like, well, I don't want to get on a birth control pill because I have an increased risk of a clot. It's like, you know what else is going to increase your risk of a clot is getting pregnant and being postpartum. So, those are the real, and at some point this week or with the week that this podcast drops, we'll kind of put that out in graphic form on our social media, because it is really nice to just see them all lined out there. And you're like, oh, well, oral estrogen's pretty stinking benign.
Yeah. I feel like we've kind of had to do a lot of educating and maybe reinforcing some of these numbers, because there's been like this patch shortage. Everybody wants to be on an estradiol patch, but they're hard to get right now because I think everybody's getting on them, right?
Yeah.
So I'm like, okay, why don't we just switch you to an oral estradiol? And I mean, almost always the comeback is like, oh my God, am I going to get a blood clot? I'm like, well, let's look at your actual risk, and let's look at you baseline, how far are you out from menopause, any other chronic health conditions, all of that. And most of the time you can, just switch right over and it's fine.
Yeah. Yeah. I mean, I feel like, again, it's one of those things like, it's a much longer conversation than just, here's your patch that has no risk of blood clots and carry on. And there are other reasons why maybe we don't love oral too. Like we talked about, the sex hormone binding globulin binds up your testosterone, the thyroid binding globulin. I mean, there are other reasons why, like, truthfully, like maybe transdermal, but I'm just saying we can't take oral off the table. And some people, you cannot get a blood level on a transdermal. They need a little bit of oral, including Mary Claire Haver, like we talked about last week, had to add a little bit of oral to her patch, which you can do because it's so cheap, and to finally get those like therapeutic protective levels.
Yeah. And start to see some good improvements like on your lipid panel and that kind of stuff. Yeah. Because you tend to see sometimes more of that with that oral estradiol, just the way that it's metabolized through the liver.
Yeah, that's what that course that we went to with Dr. Rizier when Courtney and I went out there, and that's when we recorded our big cardiovascular episode. But he really presented a whole bunch of science and data to like back this up. He really is a big proponent. He only uses oral estrogen, and he really feels like that you're only going to get the lipid benefits because that's all a liver thing. Like, you're causing the liver to increase the metabolism of your lipids, basically. And so like that reverse cholesterol transport where you're, metabolizing more through that LDL and kind of driving that down. He really feels like you have to use oral to see that effect.
I mean, even he himself takes a little bit of oral estradiol because of that,
I know. It was pretty eye-opening, but I mean, I feel like there wasn't a way to sit through it and look at all that science and then be like, I don't believe you. I mean, it was like very convincing. So,
yes.
And then I feel like this happens all the time too. Like we were talking about, the 48-year-old or whatever walks in and they're on birth control and they haven't wanted to stop it because, number one, they may have been told, well, it's your hormone replacement therapy, just stay on it. And then number two, like, they don't know if they're menopausal, so they don't want to get pregnant. So they're just kind of on this birth control pill and we don't know where we are. And I feel like it's pretty impossible to check your labs as far as hormones go. I mean, your thyroid is going to be what your thyroid's going to be, your adrenals, your testosterone. I feel like all of that is okay. Your progesterone is going to read nothing because you're not ovulating, your estrogen is going to read very, very low, like almost always like undetectably low. Because the lab is looking at estradiol and you're taking ethinyl estradiol, and most standard labs don't measure that. And so what we're measuring is your estradiol, but the birth control pill has shut down your ovary. So you're not making estradiol anymore. And so it's going to look low. It's going to look really, really low. And then your FSH, which is that marker from your pituitary gland that we use to say if you're in menopause or not, is going to be really, really suppressed because you're on this really, really strong ethinyl estradiol, and your brain is like, I don't need to ovulate or do anything. So that FSH is like, I mean, it's like lower than even like a normal ovulating person. Like if normal ovulating people is 2 to 8, I mean, it'll be 0.4 or, it'll be something just like really, really suppressed. And so, that's like impossible to say like, nope, you're not on menopause because your FSH is not, high. Well, it might be, but you're suppressing it with the birth control pill. So you can't tell somebody hormonally where they are if you check their labs on the pill. And we see this all the time. My PCP did my labs, and I'm like, but you were on this pill when they did them? Yeah, my PCP did my labs and they said my progesterone's low and my estrogen's low, but I'm not in menopause. And I'm like, yeah, that's what it's going to look like when you're on the pill. And so really we have to have you come off of the pill. We like for people to be off of it for like a month. I mean, obviously use some sort of backup. Be careful if your husband's had a vasectomy or, something like that. Come off of the pill and let's recheck your hormones so we can see what your ovaries are doing. So, yeah, I mean, I feel like the big take home point is you cannot interpret hormone labs accurately if someone's on a birth control pill.
Yeah, it's pretty interesting to see. I mean, obviously, if they're not menopausal, you're going to see some estrogen and progesterone levels. They'll start to come up. Testosterone is so crazy. Like if you check someone's testosterone level on a birth control pill, sometimes it's like 4, and then they come off of it and recheck, and then like it's actually like 28 or something, and I'm like, see, you were like shutting all that down, and now like you're actually making some of your own right now.
Yeah. I know. And I think somewhere along the way in researching for this, I saw this saying and I was like, that's so true. It said checking hormones on a birth control pill is like checking someone's natural heartbeat when they have a pacemaker.
Yes.
Like it sounds regular. It sounds like it's like 70 beats a minute and a regular rhythm. It's like, yeah, they're being paced by that pacemaker. So,
and I mean, I have seen this before, like in my med surge days, taking care of patients. I mean, even if someone is dead and they have a pacemaker, that thing is like still pacing, right, until you turn it off. So it looks like on the monitor that they have a heartbeat, and it's like, well, clearly, so.
And that's what birth control pills will do. They'll completely suppress those ovaries even when you're in menopause. Yes. They'll just keep on suppressing that FSH and all that. And so, and I feel like for most people, it's like, well, why does it matter? Doesn't it have the same stuff in it, which we've already gone through? It's not the same estrogen, and then it's none progesterone and none testosterone. But using birth control pills instead of hormone replacement in the wrong population, or like basically meaning the menopausal person who doesn't really need them, causes oversuppression of that ovarian function. It's the wrong estrogen type, going to give you a higher blood clotting risk, and it's really going to give you poor symptom control. And I feel like that is really important as we talk about progesterone and testosterone, because if you completely turn off somebody's progesterone, then you're going to mess with brain fog and sleep, and then turning off their testosterone, you're going to mess with libido and energy and mood and all of that. And so, And then I think just most importantly is that it's really lazy. That is a really lazy approach, and you're not treating the root cause of anything. You're just like masking it. Like you're just, I don't know, just, we can't figure out what's wrong with your computer, so just turn it off.
Yeah. Yes. Yeah.
Like,
and I feel like that is probably very commonly what is happening in like perimenopause, like just the crazy erraticness and maybe bleeding all the time or whatever, or PCOS. Like that's not a birth control pill is not the treatment. Like let's figure out like root cause, get down to the bottom of it and mask it all.
I know. It reminds me of like the tech support people that you call and you're like an hour into like trying to freaking fix whatever it is. And you call and they're like, have you tried to turn it back off and turn it back on? Like, no, I haven't. I've done that like 12 times.
Right. Yes. Yeah.
Yeah. I mean, and it's like, it's just so like, I don't know what else. Let's just turn it off, turn it back on. Like, we can do better than that as medical providers than just like, oh, we have no idea, turn it off. And I mean, I get the people that have been on it because it's their birth control. They've been on it, like they got back on it after they had babies. And then there is this weird moment of like, shoot, do I even need this? Do I? And I mean, you're going to have to come off of it to figure that out. That's the problem, is I feel like some people want to stay on it and figure that out. And that is kind of hard. You have to come off just for like a month and we can figure that out.
And you'll know when that is. Like whenever you start having more of these, like not sleeping well, anxiety, brain fog, libido issues. I mean, you'll know like something is not right. I don't feel like myself. Something's off. And I feel like that is usually like the 45 year old woman that comes in and it's like, I don't know, something isn't right, and I'm
That's
like,
right.
Let's see what like your actual ovaries are doing and come off. And that scares people sometimes to come off their birth control pill. They're, oh my God, am I going to have a terrible period? Am I going to get pregnant? I'm like, okay, if you have a period, like obviously that's fine. And then just use protection, like backup methods.
Just for a month while we figure it out.
Yes.
Yeah. And then, if you, just a minute for progesterone and testosterone. So progesterone, I know somebody's probably out there thinking that's the other part of the birth control pill. We got ethinyl estradiol and we got norethindrone or levonorgestrel or drospirenone or whatever that other word is, that if you look at your birth control pill pack, it's like, that's not progesterone. Like we've talked about 400 times, that is a progestin. It is a synthetic form. Like very similar to how we're saying that ethinyl estradiol is not the same as 17 beta estradiol that your ovary naturally makes. Same thing with, basically same story with progestins. They're just stronger. They bind the receptor stronger. They hang around longer. They are what is in the pill that's making you not bleed all the time. So if you just gave somebody ethinyl estradiol straight up and you didn't put anything with it, they would bleed. So you put the progestin in there because it is going to, have such an activity on that lining of the uterus and block that, and you won't bleed. So that's like the whole point of progestins, is to make your cervical mucus really, really thick and sperm can't swim through it, and to make you not bleed. Like that's it. And that's why too, they do make birth control pills that are just a progestin. And they are like, we use in like breastfeeding people that can't take the estrogen component, because you can just have such a thin lining of the uterus that you can't get pregnant. It's also how like IUDs and Nexplanon and all that kind of stuff's working. So, I mean, progestins by themselves can work as birth control, but a lot of times if you're on a progestin only like pill or shot or something that is getting systemically absorbed, it's still going to block your ovulation. And so some, there are some cases where people talk about that you still can ovulate. And that's definitely true with like an IUD. But it's not across the board true with like the mini pill or the depot shot. So, but the point is, you're not consistently getting natural progesterone. Natural progesterone, we've talked about ad nauseum, is so good for sleep, brain function, cortisol control, just like not making as much cortisol, probably because you're sleeping and in a better mood. And then the mood and anxiety stuff. So,
yeah. And then testosterone is the other piece here. So ovaries make about 50% of your testosterone. The other half comes from the adrenal production. And so, like we said, like a birth control pill shuts that down. And so, like, what is testosterone good for? It is good for our like mood, libido, energy, all of that kind of stuff. So if you shut that down, you know, you may kind of interfere with some of those things.
I know. And I feel like the even bigger problem is like if you're 40 or 45 or whatever, and you're on a birth control pill, is like your adrenal production, if you look at that graph, started going down in your late 20s. And so, and then you just shut all the way down your ovarian production.
You're
and
really losing testosterone.
You hope you're still getting 50% production from your adrenals, but they're probably lagging if they're doing normal adrenal aging stuff. So, and then you add on top of there, you're not getting your progesterone that's helping with your cortisol. So your cortisol is too much. And so then you're really going to lag
on
from
your
adrenal production. So it does get complicated, like everything with hormones, but yeah, you need all those hormones, and birth control shuts all of them down. So I think like who gets what? I think birth control obviously is birth control. It's good for pregnancy prevention. And then I feel like everybody was like, well, this is handy. We can just kind of use this for everything. And so it does make a lot of sense to like help control somebody's cycles if their cycles are irregular. And then that gets on my nerves a lot, because then you tiptoe out into like, well, you have PCOS, so here, just take this birth control pill. That is not treating the root cause of your PCOS. It is just falsely making your periods regular. So I feel like birth control was invented as birth control. That's why they are called birth control pills. And then they have just conveniently been used for everything else you know,
kind of off-label use.
Yeah.
You know, if you're hung up on like what is a birth control pill approved for through the FDA, I mean, it is not PCOS management.
Right.
You know?
Yeah. It's not.
It's to prevent pregnancy.
I get in a bad mood and have severe PMS, PMDD. Well, here's your birth control pill. I mean, you know, it's like, will that be helpful? Maybe. But would natural progesterone be more helpful? Yes, it would. And so, I mean, I think you got to just not put a Band-Aid on things.
Well, and really, we want the best options, right? Like what is going to be best for you, and the most supportive treatment options and all of that. And so looking at like hormone therapy, I mean, that is very appropriate for a woman during perimenopause and menopause, obviously, and symptom management, like all those perimenopause, menopause symptoms from like hot flashes, not sleeping well, low libido, brain fog, anxiety, like all the things, right? So like bioidentical type hormone therapy is definitely going to be a better option there.
And guess what? Per our numbers we presented earlier, it's safer too. It has less risk of blood clots. Yeah. And natural progesterone has no risk of blood clots. Yeah. I mean, that's never even really been a concern. It's always been the estrogen that we're talking about. But like we said, per ACOG, per Menopause Society, per like everyone, transdermal has baseline risk and oral has slightly higher, but not near as high as a birth control pill, and not near as high as pregnancy or postpartum. So,
and I think if you're thinking like, okay, I'm in my 40s or whatever, maybe I'm hitting perimenopause, but I'm on a birth control pill because I need it for contraception. So like, there's other options, right? If we want to like, you know, start hormone therapy or whatever you may need. There's other ways and forms of contraception that is not going to be like systemically absorbed and shut down your ovaries. Right. My favorite is your husband getting a vasectomy. Like, just do that. Yeah. or an IUD is so good for these wacky periods too.
He gets an IUD, or he gets an IUD. That, I mean, that, you know, if we shoved an IUD up there, that would be some birth control. But no, he could get a vasectomy. You could get an IUD. Have your tubes tied. I mean, something that's not going to affect your ovaries. And then get you some buckets of progesterone.
Yes, some testosterone.
Yes.
And I'm telling you, if my husband can get a vasectomy, anybody can get a vasectomy. Like,
that's right.
Some people are like, I don't know if my husband will do it. Like, it's not hard.
It's not. John had one too. So so if you've ever been told just stay on your birth control, it's basically the same thing as hormone replacement therapy. Now you know that it is not. Mm-hmm. And so if this episode helped you understand your hormones better, share it with a friend. I think we've all got to stop confusing suppression with support. They are totally different things. So, and then remember that you deserve hormone care that actually makes sense and is grounded in science, and someone can sit down and explain it all to you. So
that's right.
Yeah.
And just a quick reminder, everything we talk about here is for informational and supportive purposes only and is not medical advice. Your body is unique, so be sure and chat with your healthcare provider before making any changes to your health routine. And what are we doing next week?
Well, kind of in writing this, it got a lot into the testosterone stuff, but I think that'd be a good, just like a refresher on like, what is the deal with women's testosterone anyway? Mm-hmm. Like, how much do we normally make? Where do we make it from? Mm-hmm. What happens to it in perimenopause and menopause? And should we be on it? So I think that'd be a good little refresher for everybody. I know we've talked about testosterone before, but just sort of that natural progression, because it's very different than our estrogen and progesterone in that it really is the very first hormone to start to decline. And then I think the very first hormone we become like totally deficient in is progesterone. Mm-hmm. So it's just this weird reverse order, but everyone's obsessed with estrogen, but it's like really the last one we hang on to. So we probably need progesterone first, and then we probably need some testosterone, and then we probably need some estrogen once we ever start doing this hormone stuff correctly as a whole medical society. I think that's the way it'll happen. And that'll be starting in like women's 40s, like early 40s. And so, but that's probably a long time down the road. But just when functionally you look at what all the hormones are doing and how we're losing them and how that's happening, it seems like the logical order to replace them. So yes, y'all keep listening and have a great week.
Happy Hump Day.
Happy Hump Day.